to Nigeria a couple of years ago, and we stayed at a very fine hotel in a town called Shagamu. Shagamu?
Yes.
Shagamu. And there, it's called the Hotel Awabad, and I just want to sort of do a little promotion for that because of the, you know, but John did amazing work there in age education, and I'm so pleased that we're able to be here, and he's been on another Philoctetes Roundtable. Before we continue today's program, I want to again call your attention to the exhibit, The Aesthetics of Math, and this is attendant upon our math series. Our first roundtable was math and religion, and we had a lecture. We had a lecture the same day, and then on what was that lecture? The Lauren Graham lecture was math and naming. It was a beautiful lecture in the morning. We had naming God, naming infinity. It was in the morning. We had a lecture in the afternoon, a roundtable, and that's all been that we have two roundtables on math: the math and religion, math and beauty, funded by the Templeton Foundation, and we wish to thank them for that. But the exhibit here is in relation to that particular series of roundtables, and comprises works by Sarah Ferguson, Harish Lavani, Devin Powers, and Joan Waltermath. So sometimes people come into Philoctetes and they just think that what we have on the walls is just decorative, but actually it's something you should take a look at, and it's curated by Hallie Cohn and Adam Ludwig. So. A lot of work goes into these, and they're very much involved with the ideas that are prosecuted in these round tables. Now, tomorrow, the Rick Moody's, it's not really Rick Moody's band, but Rick Moody, the novelist, was on our inaugural round table. He's the author of The Ice Storm. Some of you may have seen the movie, Ang Lee movie. And he's coming back with the Wingdale Community Singers. This is a band that he is in. And it is an incredible band. I mean, I just love it. We play the CD at our house all the time. CDs will be for sale, but they're just going to play. And this is just an enjoyment afternoon. You should not think. Please do not come expecting to think. We won't be allowed to stay. Then on November 12th, we are back to thinking, unfortunately. It's John Ashbery's poetry. The reason we're doing the round tables, I don't understand. I've never understood a word of poetry. So I'm going all over the place trying to get someone. So we finally got a professor and a neurologist who I will be operated on afterwards. Jason Brown, and English professor Stephen Meier will be talking about. John, it's really about something called microgenesis, which I really don't understand, and the blurb hasn't helped at all. But it's an antidote to that. We're doing
the way to make more people come.
Yeah, but it should be a fabulous event. And then again, after our November 14th Mass and Beauty, the following day, a highly anticipated roundtable called The Inventions of Bob Dylan, with two major thinkers in their own right, but also turn out to be aficionados of Dylan and have websites related to Dylan. That is to say, Christopher Ricks and Sean Willens from Princeton, a history professor at Princeton, who many of you may be acquainted with his work. They will both be here. And Matthew von Unworth, Philoctetes, who runs our whole film program, is going to be moderating that discussion. And finally, on November 17th, and I'm very excited about this too, very excited, what can I say, is Daniel Mendelsohn. Many of you may know him as a classicist, teaches at Bard. His essays appear in the New York Review of Books, New Yorker, and other places. And he's talking about incredible, for me, incredible poet C.P. Cavafy. So that is going to be it's very unusual for us. It's one person, but he has so much to say that we are having just Daniel Mendelsohn on that subject. Now, yesterday was a big day for us because we learned that we are the recipient of 2 grants from the New York State Council on the Arts. Yes. So happy in music and in poetry. Polly Rosenway on our staff and Adam Woodward worked very hard for those grants. I want to thank them right now publicly for that. And we're very happy about that. We have the Templeton grant. We got money from the Department of Cultural Affairs, and most recently a grant from the Elsie Wunsch Trust. This is all by way of introduction. Diane knows this because she's in the field of trying to get money for good things. We're still sorely lacking. We're trying to stay open through December 31st, and any help we can get, we appreciate. We're looking for patrons to help us because private patrons can generally give more than the public sector can. But in any case, now, I'm pleased to introduce Ed Nersessian, who I just recently met 5 years ago. No, actually it's more than 5 years ago, right? It's about 9 years ago. Nersessian is co-director, Philippides, clinical professor of psychiatry at Cornell Weill, and training supervising psychoanalyst at the New York Psychoanalytic Institute. Ed will moderate this afternoon's panel and introduce our other distinguished guests.
Thank you.
Thanks.
We are very fortunate today to have this working, to have participants in this roundtable that present many of the areas that are, and the points of view that are important in this current healthcare debate. I should say that it's really not so much about healthcare, because I think the U.S. has pretty good healthcare. If you want to be, if you are going to be sick, I think America is one of the best places to be sick. But it's about provision of healthcare, making it more affordable and available. So I will introduce the participants, and I start with Diane on my right. Diane Meier is director of the Center to Advance Palliative Care, a national initiative of the Robert Wood Johnson Foundation, devoted to increasing the number of hospital and nursing home-based palliative care programs in the United States. She is director of the Lillian and Benjamin Herzberg Palliative Care Institute, professor of geriatrics and internal medicine, Catherine Gaisman Professor of Medical Ethics, and Chief of Division of Geriatrics for the Department of Medicine at Mount Sinai School of Medicine. Next to her is Gregory Nersessian. He's Vice President and Senior Analyst in the Equity Research Department at Credit Suisse, covering the managed care industry. He joined Credit Suisse in 2006 after spending 5 years at Lehman Brothers, with primary... Good timing for the move. With primary coverage responsibilities for the Medicaid, managed care, and disease management industries. He was voted as top up-and-comer in the 2005 Institutional Investor Equity Research Poll. Next to him is Jonathan Jacobs, who is Professor of Clinical Medicine at Weill Cornell Medical College and attending physician at New York Presbyterian Hospital. He's the founder and director of the Center for Special Studies, which is a multidisciplinary care program for people with HIV. And as Francis said, he often goes to Africa for that work. Next, there is Commissioner Robert Doar. He is the Commissioner of the Human Resources Administration and Department of Social Services. They are also running the biggest program. Their biggest program that they're running is the Medicaid program, which has more than 2 million New Yorkers. It's a large department. They have more than 14,000 employees, and it's the largest municipal social service agency and leads New York City's welfare reform initiative. He's also on the board of the Health and Hospital Corporation. And finally, Helen Morik is Vice President for Government and Community Affairs at New York Presbyterian Hospital. She and her colleagues are responsible for lobbying in the House and Senate to convey concerns regarding the interests of the hospital and its patients, as well as healthcare reform. Increasing the number of residents trained by the hospital, expanding insurance coverage, ensuring continued payments for hospitals for uninsured patients have been areas of her interest and focus. So what I would like to do is to ask you, and you can take turns either way, to see if you can briefly describe what do you think the problem is that we are trying to deal with and solve with the current work on healthcare reform. Shall I start with you?
Sure. Can everybody hear me?
Yes.
Yeah.
Yes.
I read an article last week that basically said the original sin in U.S. healthcare is the fact that there are no cost controls.
No what?
No cost controls. That essentially what drives the system is physicians, hospitals, other providers are paid fee for service, not fee for quality or fee for outcome, but fee for service. So the more services provided, the more money is reimbursed to the hospital or the CT scanner or the subspecialist or the oncologist giving chemotherapy. And not surprisingly, people do more of what they get paid to do. That's rational. And people are functioning rationally in a system that was designed, as I said 5 minutes ago, the system is perfectly designed to get the results that it gets. So that is the original sin of the American healthcare system, and it's not surprising that there's a huge amount of controversy about fixing that, because there are many interests who will be hurt. Many, many interests who will be hurt by fixing that, and we live in a democracy where those interests have as loud a voice as everyone else. And that's what you're seeing playing out right now on the floor of the House, today, in fact.
Greg?
I actually agree. I mean, clearly the biggest problem that has to be addressed is the cost problem. And it's extremely challenging, it's going to be extremely difficult. But if you look at what's going on, I think, in the Congress, there's really, there are three things that they're trying to fix. One is that there's, 45 million uninsured. There's another problem where health insurance reforms, health insurance regulations vary wildly in certain market segments by state and are, frankly, inadequate and sort of feed a lot of the, unsavory behavior that you see in a health insurance marketplace. And then, of course, managing the cost. The thrust of most of this legislation right now is around covering the uninsured. And if you look, is that me? Sorry. So
It does this.
all right. They're cutting me off already. Yeah. So
Something.
yeah, I don't know what I said. Yeah, exactly. If you look at the uninsured, so the Kaiser Family Foundation does a lot of work around this area. Recently did a report not too long ago where they segmented sort of the uninsured population. If you look at the numbers, it's pretty clear how it falls out. There's about 45 million uninsured residents. So you got the non-residents, the illegals on top of that. But you have 45 million uninsured. 30 million of those people are under 200% of the poverty level. Federal poverty level is about $10,000 for an individual, about $21,000 for a family of four. So you've got 30 million people who are generally poor or near poor enough that they can't afford their own health insurance unless they're offered it and subsidized in a heavy way. So there's about 30 million people uninsured in that category. About 7 million are children. About 15 million are adult parents. And about 8 million are childless adults. And then, so that's the 30 million. Then you've got 15 million above that. The bulk of those people, there are about 10 million of those are between 200 and 300% of the poverty level, and about 5 million over wealthy, over 300% of the poverty level. Now, of that strata that's under 200% of the poverty level, you have 7 million, like I said, children. Those people are largely addressed, or at least there has been appropriations to address that problem through the Children's Health Insurance Program, the state Children's Health Insurance Program. That was a program that was due to be sunset last year, but then they extended it for 10 years. They put a bunch of money into it. I forget what the number was, 70 billion or something like that over 10 years. And the problem is the states are too constrained budget-wise to actually put that money to work in many states, so they haven't really addressed the problem yet, but that there is appropriations to deal with it. So the other problem, which is the 23 million under 200% of the poverty level, the way that they're looking to address that is predominantly through the expansion of Medicaid, which is really the way to do it. I mean, the Medicaid program is the program that's meant to address the healthcare needs of low-income people. The problem is today, you not only have to be low income to be in Medicaid, but you also have to fit into a certain category. You have to be elderly or disabled or have dependent children, or not everybody low income qualifies depending on the state you're in, right? The federal rules differ, but then the states can get waivers around them. So what they're doing now is they're trying to open up Medicaid to more people who don't currently qualify. And I think it's a good idea. And I think really at the end of the day, no matter how this plays out politically, I think that's the foundation, that's the bedrock of this reform. And I think ultimately that's probably the one thing you can feel pretty confident will come out of health insurance reform would be an expansion to cover the people at the lower end of the income scale.
Before I go to John, you wanted to
Yeah,
say, because you're involved with
I come from
Medicaid.
the perspective of New York City and New York State, and the Medicaid program in the city of New York has been successful through a lot of changes that have taken place over many years in enrolling. Now we're up to about 2.7 million New York City residents. The Census Bureau reported last week that the percent of children in New York City that are uninsured had dropped to 5.7%, which is virtually universal coverage, and really a tremendous achievement for the state of New York. And so when it comes to coverage, not completely, but almost, a lot of the debate in Washington is about, I think, getting the rest of the country up to New York State and New York City's standards with regard to coverage, particularly of low-income citizens. And I think and that makes us a little nervous because there may be some cost shifts involved in that, and that we may be careful. It's sort of one of those things, if you do it first and you do it well, you might not get rewarded when they go around trying to find other people to get you to catch up. So we have some concern at the state level. I absolutely agree with Diane that the cost factor is a big one, and I know that firsthand because in social services, we've watched this amazing, very steady and very, very significant shift of more and more dollars, public dollars, into public health insurance or Medicaid. In New York City, we now spend about $25 billion a year on healthcare providers for low-income New York City residents for the Medicaid program. That's a lot more than we spend on food assistance. The food stamp program is about $1 billion in the city of New York. Cash welfare is also about $1 billion. In the state budget and the city budget, it's really all about education and Medicaid. They pick up now, 50% of the budget. And that is a drain and a problem for cities and states that are having trouble raising revenues. So it is about cost and it's about coverage. We happen to think in New York, with some exceptions, and we always want to get better, we do pretty well on coverage for low-income Americans. There's also the affordability question, which is people, and this is a very volatile, strong political position. There are lots of Americans that don't qualify for Medicaid and may never qualify for Medicaid, but who don't want to have to pay 25% of their income on health insurance. And that's an affordability question, and that's one that Congress is really struggling with on how to solve that one, because there they are having, to my opinion, a classic political problem. They want to give something to somebody, but they don't want to ask anybody to pay for it, and including the people that are receiving it, regardless of their income. And I don't know how that will be worked out.
Yeah, I just wanted to add, John, perhaps you can give the statistics, because I don't have them, that a good portion of the people on Medicaid are in nursing homes. And I think not everybody, and they think immediately of the mother with children, but a good portion.
Well, it's a big portion of the costs. The Medicaid
Right.
costs go disproportionately to people in nursing homes or senior citizens. That's true, although our personal care program in the city is about a $4 billion cost out of the $25 billion cost. So the numbers are a lot of people. What's interesting is another factor is the managed care role. Medicaid managed care was supposed to be a way to save dollars. The Clinton administration put a lot of emphasis on managed care, and it did, I think, slow the increase in spending. But over time, the forces of politics and citizenry and interest groups have taken the management out of Medicaid managed care. We for children in Medicaid in the city of New York and the state, there's a capita payment. They don't. It's not fee for service, but there's also very little management, as far as I can tell, about gatekeeper or reviewing of care, because that is just politically very hard to put over. People are not going to accept, and the interest groups in New York State are not going to accept an aggressive management of healthcare usage by low-income recipients. And that may be good or bad, but that's sort of where we've ended up.
John.
Well, first let me say that the Medicaid program in New York City, New York State is absolutely fantastic. I take care of patients who are on Medicaid, private insurance, and so forth, and Medicaid has done a wonderful job keeping New Yorkers healthy. It's really one of the treasures, I think, in our state. I am not. I look at this as a practitioner. You know, I don't understand the bills in Congress. You know, someone said it was the bill in the House being debated today was 5 times longer than the Torah. So there's a lot in there. So I cannot begin to, frankly, as a practitioner, understand the finances, which is unfortunate because finances is so important. But I would look at 3 things that as the problems that we are trying to solve from a patient's point of view. One, I would say, is seamless care. Just to give some anecdotes, I have a patient who I prescribe HIV medications to. They must be taken every day. Unfortunately, he has private insurance, which pays for the first 8 months of the year. After that, he can't get it. And he has to try to cobble together some sort of package to try to possibly afford these things. So we have a system that is not seamless from the perspective of the patient. Second, we have a lot of misunderstanding about healthcare and healthcare reform, insurance reform. I had a patient this week come in and tell me that, you know, he's very nervous about healthcare reform. I think we all are. And he said, you know, I saw the president before he was elected at a campaign stop, and he was embracing this woman who said she couldn't access health care, and this woman, you know, must have been 350 pounds, and, you know, it's really her job to get healthier so that, you know, perhaps health care won't cost so much. You know, why should I have to pay for her health care? Not realizing, of course, that, number one, if that woman goes to the emergency room, he is paying for her health care, somebody's paying for her health care. And number two, if she had access to a physician who could counsel her about all sorts of health issues, maybe it would ultimately become less expensive for all of us. And the third I would say is that it's obviously very complex. For my patients, they have to have access to me, to their medicines, but they also need access to other things such as nutrition and transportation. These are critical parts of healthcare, and I'm not quite sure how that gets paid for in a healthcare package. And, you know, we have at our hospital, Mount Sinai, we have medical residents. We're trying to educate doctors. We have to pay for that, but, you know, how is that paid for? You know, if I go to a hospital, I am charged something for the services I receive that has nothing to do with the cost of the services I receive, but that price is predicated on not just the services I receive, but also educating people and doing all sorts of things. So there's a certain lack of reality in terms of healthcare pricing. So we have all these very complicated problems. The bottom line is that we pay a lot for healthcare. We don't do as well as other places in the world. Fortunately, you know, as we try to conceive of all this, we don't have to reinvent the wheel. There are examples we can look at, but we have to bring down costs. But at the same time, more important, I think we have to make our care better. And I think you can do both at the same time.
Yeah, I'm glad you raised the issue of training physicians, because that's been one of the things that I've been focusing on, particularly with our legislators and our senators, and letting them know these are critical issues for us at academic medical centers, in urban centers particularly, because a lot of our residents do provide care for people on Medicaid, but also to look at it in the long term. Right now there's a cap on the number of residents that we can train in the country. And that means that we can't train more than X number, and I don't know what the entire number is. But as we look ahead, and the more people that we begin to insure, hopefully under this new plan, we're not going to have enough doctors to be able to take care of all these people. Right now, people complain in major academic medical centers in New York that it takes 3 or 4 months to get an appointment with a specialist. You go into an emergency room and you're waiting hours to be cared for. And a lot of that has to do with the fact that we don't have as many doctors as we should have. That's going to get far worse. So fortunately, graduate medical education is not being cut, and that's the piece that that trains physicians and comes into New York and other places across the country. We train here in New York State, almost 20% of the doctors who are deployed throughout the country. And they don't all stay here, obviously. They go, go to other parts of the country. But that's a big piece of our economy here in New York. We have to look at it that way too. The economy here in New York, healthcare is the #1 industry outside of government jobs. Government is #1, and the #2 in New York State is healthcare. And a lot of
Not
it has
Wall
to do
Street.
with, excuse me?
Not Wall Street. but
Not Wall
healthcare.
Street, not communications, not, as a matter of fact, New York Presbyterian is the #1 employer in the city of New York. So, these are things that not many people know about. And we've tried to convey this to our legislators, and that has been the message that I've been bringing to forums like this as well as to the legislators. And they are listening. Our senators and our members of Congress here in New York do get it. They do understand it, because it's been a constant message. It didn't just come up this last year on health reform. We're constantly sending the message that this is critically important to New Yorkers, to the provision of health care, and also to the economy of New York. So while we're concerned about jobs, we got to keep that in mind.
I just wanted to go back to Diane's point. I think the original sin of fee-for-service, I think, is critical to all of this, because just very conceptually, if you really want to boil this down to why the costs are out of control, you have this ecosystem of providers and hospitals and suppliers, manufacturers, that their financial incentive is to maximize the amount of revenue that they can extract from the insurance industry, right? The insurance industry's role is to try and mitigate that rate of cost growth. Some people think they go too far, some people think they don't go far enough, but they're kind of in the middle. And the reality is they're really fairly powerless in terms of the extent that they can really mitigate that rate of cost growth. 10 years ago, they were a little bit more aggressive. There was a big backlash, and ever since then, they've been neutered to a certain extent in terms of what they can do to mitigate that cost growth. So what do? They pass it on, right? So they just take it. And the dirty secret little secret of in the insurance industry is faster medical cost growth means more dollars in the system. If they're earning even a very small margin on that higher rate of growth, it means more profit growth to them, right? So they're not necessarily incentivized. They don't have the proper incentives, in my opinion anyways, to really mitigate the rate of medical cost growth, right? But that's sort of their role, and in the competitive world, if somebody else is doing a better job of it than they are, they could see business move away from them. So they do, as long as they all do a little bit, then they all stick around, and then they pass it on to who? The employers and to the government, right? So at the end of the day, and then what do the employers do? The employers pass it on to their employees in the form of foregone wages, and to their owners, their shareholders, and the owners of the businesses in the form of lost profits, right? So at the end of the day, it's the employees and it's the owners of these businesses on the commercial side who are funding this, out of control cost growth on the part of this provider and community, right? So the question then becomes, is there a way to improve the financial, to align the incentives better between the providers of the care and the insurance companies or the employers or the government, whoever it is, in order to eliminate the fee-for-service and focus it more on the quality of care and just doing enough. But to do that, you need to take an important step, which is to allow the cost to enter into the decision-making process of the provider of care, right? And that's what the Mayo Clinic does, and that's what Kaiser does, and there's some examples of that have been successful doing it, but that's something that's extremely controversial, right? Yeah. Do we want providers making decisions on care that incorporate the cost of delivery?
My experience in the state and the city has led me to believe that you might not have to get all the way to there if you could do some other things first. The state, in the programs that I run, the issue of quality control is a big one for people who access our benefit programs for cash welfare or for food stamps. We're under some obligation and some very intense audit requirement to make sure we get the decision about their eligibility correct. And there are penalties associated with making rampant mistakes in that. That's welfare fraud and welfare waste and abuse. And we're, in the city of New York, sometimes good at it and sometimes not so good at it, but we feel that pressure all the time. In the Medicaid program, which is by far much larger, for whatever reason, over many years, that pressure on quality control, on documentation checking, on being sure that the bill is for what we're paying for, not even appropriateness, just that it was properly submitted and wasn't, 6 bills for 1 care. There's really nothing there from either the state or the federal government. The Medicaid quality control function is not there. Provider quality control or review of providers' bills is not very significant. And we could have, I think, done a better job, and we still could do a better job at auditing that and getting significant saving. The current governor's administration has bolstered the Medicaid Inspector General's office and asked him to do that. But again, you run into, when I impose eligibility criteria that's strong and tough on low-income New Yorkers who want to be on welfare or food stamps, the political backlash is non-existent, really. None. When the state imposes quality control reviews and audit controls on the healthcare industry, I'm sorry to say, that is strong and tough about making sure the bill is right and it's done correctly, the political backlash is intense. And that has been a real problem in our healthcare system in the country. That has made us not able to at least control the public costs.
But all the interest groups are working very rationally from their own perspective. I mean, everyone is working rationally to maximize their access to resources to keep these hospitals open.
When I'm on the Health and Hospital
community.
Court Board,
Right.
I'm, don't audit us, what are you kidding?
Right. But I think the point that we also haven't talked about is the runaway cost is not your average healthy 72-year-old. That person who has great care under Medicare, fantastic access, is not where the problem is. The problem is in a very small subset of the patient population with multiple chronic advanced diseases. And the ratio, and this is true in Medicaid as well as Medicare, is that the sickest 10% in Medicare, in Medicaid, and it's actually the sickest 5% in commercial insurance, drive 2/3 of all spending. Now, why is that? The reason for that is both that if you have metastatic lung cancer, you're going to get a PET CT every 3 months, even though there is no data that getting a PET CT every 3 months is going to improve your outcome. But all the insurers will pay for it, and it's $2,000 or $3,000 a pop, not to mention a huge amount of radiation. And people think that's better care because more must be better. The other major problem is that there is no safety net for people with chronic complex illness other than the hospital, because there are essentially very few adequate community resources. So that in other countries, if you run out of pain medicine Saturday at 3 in the morning, you do not have to go to the emergency department. You can get help. There's coverage. There's people who can take care of that for you in the middle of the night. In this country, you have one option. You go to the emergency department, whether you're rich or poor, at 3 in the morning on Saturday. Well, what's the most expensive setting for healthcare? It's the hospital, but it's the only safety net that exists in our country. So until we build community resources and bring the care to the patients at home, we're not going to control costs. Hospitals are not expensive because they made a decision to be expensive. It's very expensive to run these institutions, and that's where that sickest 10% in all insurance markets gets most of their care. And in fact, that's a myth about Medicaid. 75% of Medicaid is acute care. Of the total
Not
Medicaid.
nursing,
The cost.
Yeah, 75% of the Medicaid
Not the number of
dollars.
recipients.
not the number of
No,
recipients.
No, but the
Right.
dollars, and the dollars are what matters. It
Right.
is basically poorly spent money in acute care hospitals because people have nowhere else to go. They don't have primary care. They can't reach anybody at 3 in the morning if they have a problem. So they're on a revolving door in and out of the hospital. And these are the most sick, most complicated patients in all insurance markets.
Yeah, a little sub-note on that, it's all, I agree with what you're saying and the facts are correct, is that in New York City, unlike the rest of the state, and I think many parts of the country, we have a very well-developed personal care program which provides home health aides and personal aides in homes for mostly seniors who are not eligible for nursing home but need help with their daily lives. And so now in New York City, we're up to about 40,000 recipients of these personal care aides on any given day. And it costs about $4 billion. It's an expensive program. What's interesting is that the State Department of Health has decided that is also an area that is spending too much, although to some extent we're keeping people out of nursing homes. And that we need to look at that and really examine that carefully. And I'm willing to do that. I'm anxious about that. And sometimes the stay-at-home decision, if it's 24 hours, split shift, no sleeping, that is more expensive than nursing home. And so sometimes we can go too far in trying to keep people in the community. But a lot of the discussion is around acute care. There's no question about that.
You point out that there's no more expensive care than what you might get in a hospital in the emergency room. But for people with both chronic illness and for the poor, even under the Medicaid program, it would be great if they could, call someone at 1 o'clock in the morning if they're having pain. If, most Medicaid recipients get their care through clinics, and good luck trying to figure out who's taking care of you or who you might want to call if you have an acute problem. And that's something that can actually be changed. It's sort of been a traditional academic medical center approach to the poor, but it doesn't necessarily have to be that way. I don't think it would necessarily be more expensive just assign people to physicians, just like the otherwise insured population does. And I think that would go a long way to keeping people out of very expensive settings.
Well, when I was a resident, I was moonlighting. And one of the things I was doing moonlighting was getting calls for certain hours. Let's say I was on call from 6 p.m. to 6 a.m. In Queens. So I would be in my car and I would call this central number and they say you go to such and such a street and see this patient. I go there, see the patient. They pay me $20, then I go somewhere else and I keep doing this all night. So those people didn't go to emergency rooms. They called this number and the doctor arrived. This kind of thing doesn't exist anymore.
Well, now, again, for most academic medical centers at least, it's seen as a training venue. So you have the intern who takes care of the person that comes to clinic, or you have the fellow. It's never the same person. Again, there is no continuity, which also I'm sure adds costs. One thing that I don't think is actually part of this bill, but which has been talked about a lot, is the patient-centered medical home. And it seems bizarre that we have to come up with a program to center care on the patient, but nevertheless, that's how it is. But it is the patient-centered medical home, which is this program that requires you to have 24-hour emergency care, requires you to have the electronic medical record so I can see what happened to a person in another hospital. That is, I think, a very good step, if it works, towards, again, providing continuity of care, providing more seamless care, providing more compassionate care, I think.
I think that that's a very good point. We're right now at New York Presbyterian in the northern campus, which is Washington Heights and Inwood, where we have a large immigrant population, a poor population, but also a paying population. We are now embarking on just exactly that, the medical home. We do have, clinic patients do have their own doctor in all our primary care settings, and that's only uptown. And we are embarking on a new initiative, hopefully to roll it out in January, that where patients will have a medical home. Obviously, it's going to take a long time. The thing is that I'm not so certain that's going to be less expensive, especially initially. Will it be better care? No question about it. That people will be able at 3 o'clock in the morning they'll have a telephone number where they can call somebody. But in the long run, yes, probably it will be better care because we'll be focusing a lot on preventive care. Right. That's the one thing that nobody seems to talk about. prevention is really the key. When you talk about that 350-pound woman, well, she should be getting preventive care so she won't reach that point. And that is going to be our focus. Again, I don't think it's going to be less expensive in the beginning, but overall, hopefully.
It's also the direction that the state Medicaid department has
Right.
taken in the last couple of years. They've cut reimbursement rates to hospitals for in-hospital care in order to achieve some savings, and then they've increased reimbursement rates for clinical care and outpatient care. And an organization like the Health and Hospitals Corporation, which has both, is feeling a lot of pain in one place and is hoping to shore up and improve our performance in other places. And I think that's really the other big thing, that whether the bill passes, or especially if the bill passes, or whatever comes out of Congress passes, there's going to be a period of time where we're going to be changing a great deal. And the pain of that is also going to be, it's not, I think that sometimes people, I know no one in this room, of course, but some people might think that these things, these changes can happen overnight very quickly. But this healthcare, this is going to be really, and there are going to be people that perceive themselves as winners and people that will perceive themselves as losers. And there's just no way around that, I don't think.
I'd be interested in hearing what your perspectives would be on what the private sector's role in that could be, because there's a big emphasis from the companies that I cover that are involved in the Medicaid program, arguing that if you pay us a flat rate per member, we now have the financial incentive to provide those kinds of services, have nurse calling centers, those things on hand, because if that person ends up in the emergency room, we get cleaned out. Right, right. So we do everything in our power to try and mitigate that. So that's why they're trying, but there's very, very little managed care in that long-term care population. A little bit in New York, but in most states it's almost non-existent.
But it's fascinating to watch the insurers. Aetna, United, Cigna are way ahead of Medicare on recognizing that case management, complex care management, even though it costs them money, the return on investment is 6 to 1. So they've got like nurse case managers who may be by telephone. It's all by telephone. It's remarkably effective to have a human being at the other end of the phone. And the ratio is about 60 to 1. 60 cases per nurse case manager. And that's for not that extremely sick. If people are extremely sick, it's 1 to 25 patients. And they reduce hospitalization and emergency room visits by 80%. And they save a huge amount of money. Now, if Medicare has never done that. So where do these complicated sick people go? They go to the hospital because there's nothing out there in the community. There's no safety net. Whereas the fee-for-service commercial market or the private sector has been much more creative and much more able to kind of turn on a dime and create ways of meeting the patient's needs. And what's interesting about it is they don't go through the physician. They go directly to the patient, and they offer the service. And they don't have to ask a doctor for permission, so they get past the barrier. The doctor is often the barrier to rational care, frankly.
I don't know about that.
They bypass the doctor. If they want to, say, recommend a new pharmaceutical, they talk to the doctor. But in terms of preventing an emergency room visit for constipation, they don't need to call the doctor for that. And they get
It works.
Done. It works really well. And Medicare has not been able to follow in the footsteps of the private sector, but needs to for that patient population.
Yeah, it's true. We also haven't talked about the role of health information technology, because that's really the future. And we did a demonstration project at New York Presbyterian, the Uptown campus, where we gave computers to mostly elderly people who had never worked a computer before. They had to actually be computer dummies, for lack of a better term. And we also put them in a rural area up near Syracuse and gave people who had diabetes, we gave them computers, and they were able to monitor their sugar levels on a daily basis and notify immediately, not necessarily a physician, a nurse practitioner. It's less costly if you're using nurse practitioners, by the way, to monitor their diabetes levels and what they needed to do if the sugar was going up. Well, we had dramatic drop in admissions to hospitals because people were really paying attention. They were monitoring it themselves. Of course, it was very costly. It was a demonstration project to put computers in everybody's home, but it is something that obviously in the future, when more and more people have computers and you can manage your health care via computers, sounds almost extraordinary, but it'll be the way to go.
And I just to also follow up on your comment about the private sector and yours as well. We've had those demonstrations too. The private sector providers of healthcare have come to us and said, look what we could do if we were managed care for Medicaid or long-term care providers. And we have experimented with it and looked at it, and it definitely has all kinds of wonderful qualities, so long as the provider doesn't drop them when they get really sick. That's a big problem. They got to stick with them, because then they just come back to us, and that's something that needs to be built in to the system, because if it has the rules.
Yeah. Yeah, so there are a number of states doing different kinds of pilot programs on that front. But, you know, I mean, then you get down, you start going down this road of, okay, so in the Medicare Advantage program, the Medicare Advantage companies are doing a good job, I think, of managing some of these chronically ill patients. They're being paid a flat rate. The better job that they do, the more profit comes to them. And on the other hand, they're being vilified in Congress and in publicly for having profit margins that are, in some people's opinions, excessive. At the same time, they need higher margins in order to get capital investment from investors in order to develop the IT systems and the technology in order to support those programs. So you're constantly in this structure where you're incentivizing the health insurance companies financially to control costs, yet on the back end, you don't want them to control costs too much, because then they become too profitable, and then there's something wrong with that too. So, but there are other models. I mean, there's the state of Texas in their Medicaid program. I don't know if you're familiar with their Medicaid program. Not good at all at covering the uninsured, but they do have a relatively developed managed care program where there's a gain sharing arrangement where if the managed care company earns in excess of a 3% margin, there's a graduated scale where some of the excess profit gets shared back with the state. So in other words, it's sort of a profit sharing arrangement. If the state is incentivized to give the managed care company enough of a rate increase every year that they can control their own profit margins, and yet they know that they'll get something back at the end of the day if there is. So there's ways you can manage around that, but at the end of the day, you want the health insurance company to be incentivized to control costs, but you don't want them to do it so much that their profit margins are too high.
Well, one of the problems with insurance companies is that they too often deny care, deny payment, or they deny coverage, or like the patient he was talking about. I mean, it seems to me the most ridiculous thing that the patient who needs medication all year round, they say we only pay for 8 months. That there is something completely illogical in that way of looking at healthcare.
So, the health insurance industry, you really need to segment it, because it depends on what kind of coverage is being offered. I don't know where this person gets their insurance from, but it sort of depends. If you work for a large employer, right? Really, if you work for any employer, but the regulations vary by the size of the employer. If you work for a large employer, that decision is really made by the employer. The employer is the one who designs that benefit plan. Most large employers have their own human resources departments that design these benefit plans and carve out exactly what will or will not be covered. And the insurance companies, in fact, most of them don't even take insurance risk. They're just administering the claims, and all those types of decisions are made on behalf by the employer. So, and most people, frankly, are happy with that coverage. I mean, most people who work for large organizations, everybody complains about their health insurance company, but they don't complain any more than they complain about their cable company or their phone company or anything else, right? I mean, most people in large any more than they complain about their cable company or their phone company or anything else, right? I mean, most people in large employers are okay with their insurance.
A lot of things not working well these days.
Right. It's the bigger issues, frankly, are in the small group. There's a lot of mixed regulation in the small group if you're an employer who's got 50 or under employees, but it's really in the individual market. That's where the bulk of the inadequate regulation is in the individual market. If you're an individual going to buy health insurance, it's extraordinarily expensive. The coverage in an employer sponsor, the actuarial coverage is about 85%. In other words, you're paying 15% and the plan itself covers 85%. In individual, it's like 60 or 65%. So you're paying a much larger percentage of it, and the regulations are so poorly designed, or, you know, frankly, in my opinion, across these different states, that they allow for things like what you're talking about, where there isn't expansive coverage, where things aren't guaranteed, where the insurance company can rescind the insurance when you're sick, they can exclude you from the insurance based on pre-existing.
I mean, I think it comes, yeah, I'm sure all that is true. I think part of the problem comes from looking at it first from the dollars perspective, because I think what happened with this individual is that he has prescription coverage, but only to a certain amount. And this is not, you know, this also occurs, of course, with the Medicare prescription coverage. I'm not quite sure what anyone thinks is going to happen to a person once they reach that donut hole. Is their disease going to go away? You know, it is just conceived of in a way that is, you know, it's theoretical, it's based on finance, but I think you have to look from the other way. You have to look from the patient and what they need. Again, I think if you could figure out a way, and again, I don't know how to do this, that starts from the patient and not from the money, you probably will end up with a system that doesn't cost anymore, that people will be more satisfied with. You know, again, to give another example, I have patients who are on the ADAP program, which is for people who not poor enough for Medicaid, but anyway, so I can give them certain things. I can give them my services, but it doesn't pay for mammograms. So my patients in ADAP don't get screened for breast cancer. That makes no sense, you know, in terms of our society, but also it just, you know, if one of those women develops breast cancer, it's going to be pretty expensive, and my guess is that if you look at a cost-effective approach to it, it's not very cost-effective.
And I mean, those points are true. I mean, the donut hole and those coverage limitations and maximum out-of-pocket costs, all those things, all that really is designing different ways for the individual to bear more of the cost, right? Because at the end of the day, Medicare is it's funded from federal taxpayers. So it's either being paid for by the individual or it's being paid for by the taxpayer, right? So at the end of the day, the donut hole is just a mechanism to get the individual to pay more and the taxpayer to pay
understand
a little bit less.
but unfortunately, they stop filling their prescriptions. That's what happened.
The goal, the intent of it was to get them to switch to generic medications where possible, because those would be cheaper and they would be.
Right.
But whether or not that.
No, I think, you know, I understand the goal, and I think we, you know, have to come up with a way to pay for prescriptions that isn't, you know, exorbitant, but it just doesn't make any sense.
Well, what really doesn't make sense, in my opinion, is that the lack of transparency in the price of what's paid for health insurance ends up with a situation where if you are uninsured, you're paying multiples in terms of the bill that, you know, what you're billed by that hospital or you're billed by that physician is multiples of what it would be if you were insured, right? In other words, if you go in for an overnight.
Right. I mean, the hospital has to set an arbitrary price for how much they charge, and you know, that is something I think that also adds enormously to costs. And again, it is there's no transparency there. I think ideally, for instance, again, I don't know why Medicare should pay for house staff education. I think the government should support house staff education, absolutely. It's critical, we have to train doctors. But why should it come out of Medicare in particular? I never understood.
Well, it's an add-on to the Medicare.
I understand that.
Well, it's government funded, however you want to pay for it. As a matter of fact, Daniel Moynihan, our senator who is no longer with us, used to propose exactly that there be a separate fund for graduate medical education. And that would have been wonderful, but nobody has ever been able to get that to pass. So I don't disagree with you. It's just that it is the mechanism that is used by the government, but it is paid for by the government.
You know, when I work in the Medicaid program, which is mostly children and poor New Yorkers under 65, with the exception of long-term care, because they get Medicaid as well. So I don't talk much about Medicare, but this does raise another big issue, which is the fact that the demographics of our nation the aging of our nation, and the cost, just the regular cost, not mean-spirited insurance companies or tough or abusive hospitals or whatever. It's just going to be expensive to care for the aging population in America. And I think to some degree what they're all fighting about is who's going to pay for it. And we have to decide. We're going to have to pay for it. And the question is how can we make it so that the transfer of really income and resources from the young to the old is not so debilitating that we don't have anything left to
But there are countries, John was saying, that do that, who have found a solution to this problem.
Yeah, I think, again, I'm not an expert on all this, but yes, it's my understanding there are societies that do provide sort of cradle-to-grave care that, where people, that's not fragmented. It's seamless and people can get the care they need. In terms of Medicare, though, and again, I'm sure Diane would agree that in addition to this enormous burden that's coming up financially, the fact is that there's not the expertise to care for this aging population. And so, again, one thing that comes up is that, the way that care is delivered now, where internists will see people for 10 minutes at a time, whatever it may be, is really not the sort of care that the elderly require. And we have to train doctors. Someone has to pay for training doctors to provide this care, so we don't have all these invasive cardiologists, but no geriatricians and no primary care internists.
Right.
And what's the irony, of course, is that it's the taxpayer paying for this.
Right.
The taxpayer is paying for more. My husband's an interventional cardiologist. Full disclosure here. Medicare is paying for the training of, very high-tech subspecialists and paying almost nothing for palliative care doctors, geriatricians, primary care doctors, family practitioners, because it exerts no control, even
Yes.
though it's supposed to be serving the Medicare population.
Actually,
Over what the specialization distribution
as
should
I
be.
talked about earlier, in the bill, in terms of raising the residency caps and making sure that we still pay for graduate medical education, that is being addressed.
It's
That
in the bill.
Yes,
Yeah,
it's in the bill.
it's in the new
That,
bill.
in other words, at least 25%, if not more, of the new residents who are trained should be primary care specialists. I think it's more than 25%, I can't remember, because you're exactly right. That's where the preventive care will come in. If you have a primary care physician, you don't really want to wait to get to the specialists. I think most of us would rather not have to ever go to one of those specialists, with the
Unless
exception
you're
of your
John.
husband or John. So just making certain that we can train those physicians, yes, I think the idea is to increase the primary care population substantially over the course of the next 25 or 30
And of course,
years.
pay more for primary care so that medical graduates have some incentive for going into that field.
Well, that's the other piece of it. That,
Yeah.
Minor detail.
But I would ask the healthcare experts, because I'm not a physician, is in the long run, do the studies really show that preventive care is the greatest, and we want people to see doctors, but will they really reduce costs on the chronic conditions?
It depends on the type of
Right.
preventive care. So people will argue that if you have comprehensive universal preventive care, people will live longer and it will cost more because they will live longer.
Right.
But
That's
there are,
bad.
right. But it really
No, it's not.
too generic of a statement, because there are some types of preventive care that markedly reduce cost, and it's not cancer screening. It's things like monitoring people for the development of diabetes, monitoring people for the development of hypertension. If you can prevent a stroke, you can save a huge amount of money for better
Exactly.
quality of life gains.
Correct.
So you have to segment that prevention world. In some things we do because we're neurotic, like everyone wants their PSA done every year, and some things actually do have a real beneficial impact not only on quality of life but cost. So that it doesn't tend to get spoken about as accurately as it should.
It's hard to tell somebody that if the technology exists, well, you can have it, but you can't. Because if it's your dad, you're going to want to make sure he gets the best top quality care. And we're all, that's human nature. We all want the best that's out there. And we want to make sure that our family members all get the best top quality care and the latest technology available. And so it's very hard to say, you know, as Diane said earlier.
The problem is best is not more. And we've mixed up more with best in this country.
Yes, I was just going to get, you're right.
We've got this entrancement with technology. If the technology exists, it must be better,
Right.
and I want it.
Right.
And actually, the literature suggests the opposite. If you've got a CAT scan every quarter, your risk of getting another cancer from excess radiation.
Yeah, well, that's
exposure.
excess.
But-
Yes, that's excessive.
But
Yes.
if you've got a patient in your office, they want that CAT scan because it must be better to get more diagnostic tests. You know, logically, we should all be getting total body CAT scans daily. Something might develop tomorrow, it wasn't there today. But that is what's driving.
Right.
a
Well,
lot of
it's
the
also, we haven't talked at all
over-treatment
about the
and overuse.
malpractice costs. And that's another issue. And it's very, we need malpractice reform if we're going to ever control costs. Here in New York particularly, we pay a huge amount, doctors pay a huge amount. I'm sure, John, that you pay a lot of money for malpractice. Hospitals pay a lot of money for malpractice costs. We're not saying that people where a doctor was, committed malpractice, that they should not be compensated. But some of the frivolous lawsuits that come before doctors, for example, when babies are born, the idea is many of them are born with congenital problems. It's not necessarily the doctor that committed malpractice. It's that's the way the child was born. There should be a fund available, whether it's state funded or whatever it is, that every child who has needs, special needs, should be taken care of. It shouldn't have to come down to parents going and filing lawsuits in order to get the care that their children need. So there's a lot that can be done that would make it better and a little bit less costly, but that's not being addressed at all.
Right.
Because
I'll tell you,
politically, it's a hot
it's
potato.
a funny thing. Mayor Bloomberg
They won't.
is briefed on the status of the healthcare legislation and issues affecting where we are as a city policy and city advocacy. And he always brings up malpractice as something he wants. Is why can't we? And it's so interesting to watch because the various people that are talking about it. It gets no traction anywhere, and he gets so frustrated. And then it gets dropped, and we move on to the next thing.
Right.
But it is an unfortunate aspect of the debate that it doesn't seem to catch on significantly.
Right. The president did say that it is something he wants to address, not in this bill. It won't be addressed in this bill, but hopefully.
So
It's
those
interesting,
of
the
you
thing
who
about-
know,
Real quick, just on the medical malpractice. The issue with the medical malpractice from the insurance perspective is actually, dollar-wise, it's not huge. It's probably 2 or 3%
Not huge
aggregate.
for whom?
In terms of those costs ultimately from the provider's perspective get pushed down to the rates that they have to charge from insurance companies or from the state or whatever, right? So as a percentage of total spending, it's 200-300 basis points. It's a couple percent, I think. It's not a huge number, but the problem isn't necessarily the claims themselves. It's the defensive medicine that's got to be practiced in
That's
order
what I was
to
getting at.
avoid
Exactly.
those claims.
That's
Yes.
exactly what I was getting
that's
at.
the number of scans or the
Right.
Yes.
The perception
Exactly right.
that I'll get sued if I don't do this is much
Right.
greater than the reality.
Right.
Right.
And what drives
true.
lawsuit is not failure to order a CAT scan. It's rudeness, indifference, lack of respect, not spending enough time. And the data is very clear on that. But doctors don't seem to
Hasn't
register.
penetrated.
It's about treating your patient as a fellow human being. That's the best way to reduce your risk of getting sued.
Well, that's why I think it was Senator Clinton when she was campaigning for president. One of the things she said was we should have this, if a doctor makes a mistake, he immediately should apologize. It was the I'm sorry, and it's not, it sounds kind of trite.
there's literature
But
on that
yes, there is.
Well, there was the guy who operated on the wrong side of the brain out in Staten Island.
Right.
Well,
I mean,
that patient
you
should
could've
be
just-
compensated.
Yes, exactly right.
Could have said,
yeah.
I'm sorry.
Yeah.
couldn't understand
No,
the
it wasn't
apology.
limited to
I didn't
that.
need to.
No. It wasn't limited to saying I'm sorry, but to own up to it, and then to proceed from there.
Right.
But so, what is it that is happening now, those of you who know, in Washington? And what is it they're going to solve? And what is it they're not going to solve? And and how is it going to be any different if they do whatever it is they're doing?
Well, today they are debating the House bill, the House of Representatives bill.
Which gives us
The-
what and takes away what? Do we know?
Well, well, one of the best things, and I said this earlier about any of the bills, is that it does eliminate pre-existing conditions. So people who have pre-existing conditions will be able to get Medicare. Now, it doesn't kick in,
Not Medicare.
Health
insurance, I'm sorry, insurance. It doesn't kick in until the year 2012 or 2013, which is which to me is, that's something that you would think they could do it tomorrow. But that will be in the bill. The specifics I have.
There's really two big things in the bill. At the end of the day, there's two structural things, changes in the bill. One is Medicaid, lifting this categorical eligibility requirement for Medicaid. It doesn't matter who you are, what you are, if you're under 133% of the poverty level, you are eligible for Medicaid.
Which won't help us here in New York, because we are already over that.
So
But
that's money.
nationwide.
Yes,
Nationwide.
it's good for the, very
Yeah.
big for the country.
Right,
Nationally,
exactly, right.
there's about 15 million people who will get covered, or who will be eligible for coverage. Whether or not the state's going to actually find them and enroll them is another question. But 15 million people right off the top covered in Medicaid, which is an enormous step. I mean, has enormous implications across the delivery system to do that. But that's step one, and that's in every bill. House, both Senate bills,
Right.
everything that's in there. That's sort of what I was saying before, is the bedrock. The second piece is for people who are between 133%, it depends if you're talking House or Senate, but 133, 150% of the poverty level, and 300% of the poverty level. The goal there is a little bit different, and I'm not sure people have fully thought it out, but basically it's to sort of emulate what they've done in Massachusetts, which is create a private insurance exchange, a public insurance exchange where individuals can go, either it's a government agency, you either call it or go online or do whatever, and this government agency will have negotiated contracts with health insurance companies, and you will be able to go there and buy that insurance at basically a big group rate, as
And
opposed to.
subsidized.
You'll be subsidized, yeah,
And
that's
you're
the key.
subsidized between 133 and 300%, you're subsidized.
Right.
Over 300%, you have to pay with your own dollars, but between 133 and 300, you get some kind of subsidy. But to do that effectively, you have to do two things. One is eliminate the ability of the health insurance company to deny people care, right? The insurance company has to cover everybody who goes to buy insurance out of this pool, right?
Right.
Whether they have pre-existing conditions, whether they are overweight, whether they smoke, it doesn't matter. They have to cover everybody, right? To do that, that's what's called guaranteed issue. To do that, you need to force everybody into the pool.
Right.
You need to have everybody
spread the
participate,
risk.
because if you don't, people will just wait until they
they're
need
sick.
care to go in there, and it's going to drive up the cost of the insurance in that pool, make it completely unaffordable for everybody.
Well, the whole
So what
point
you
of
need,
insurance is that 95% are healthy, but they're
Right.
paying in.
Right,
The 5% who are sick.
So that's
It spreads the
there's a
risk.
mandate in the
Spreads
House
the
yeah,
bill.
risk.
that's the mandate, right.
Right.
Yeah,
So in
it's an
all of
insurance
these programs, there is a mandate on the individual to have insurance, right? Or they have to pay a penalty. And there's a big debate on how you set that penalty and what kind of incentives those could lead to. And I think in the House bill, there's also I may be off on this, but I'm pretty sure it's the House bill, there's a mandate on the employer,
Right.
where the employer has to cover
Pay
their
everybody.
employees, right. So, but you need all those things, and
Right.
if you don't have any one of those things, the whole
Whole
thing
thing
doesn't
collapses.
Right.
fall.
The
kind of falls
problem there
apart.
is, and I agree with you, the problem is that the penalties, in case you're an individual and you say, well, I'm not going to have, are not very substantial. I mean, I think it's like $100 if you don't want to get health insurance. Well,
That's
you
a
know,
joke.
there'd be a lot, exactly, that's a joke. The same
Right.
on the employer side. They have to fix that, because otherwise many employers will say, oh, I'll just pay the $750
This is
per
democracy
employee.
at work.
Right.
This is
And,
what they
yeah.
can get.
So
that's
So-
what they're going to get.
that's an issue.
So the issue then becomes, you set those penalties too low.
Too low.
The cost of the insurance goes up in the
Right.
pool, because now it'll be all sick people. in there.
Correct.
You set them too high, the cost of the insurance is going to be lower, but
can't
you're
afford
forcing people to pay a large percentage of their
And that's
income
not
for the insurance.
politically tolerable.
Right.
People will
So
lose their
that's
lives.
really the crux of the debate.
And
I
also
would
in
argue
the-
has
on-
moved from public plan and all this
on the
other kind
House-
of
in the House bill-
frills to this, really.
In the House bill, they are taxing people over, giving people who
Yeah.
earn 500,000 and above have to pay a surcharge on their taxes. So,
Right.
and because somebody has to pay for all this.
Right.
And, that's the other piece of it that's difficult, but
Right. Right.
Couples
So
over a
House
million,
bill,
I
it's
believe, yeah.
is based on income. Senate
Right.
bill, they don't have that.
They don't
Senate
have
bill,
that
they
in the
tax
Senate.
the insurers and they tax the
Right.
device companies and try and do it backdoor, right? I mean,
Right.
those companies then
Right.
pass it along in the form of higher health insurance. Everybody's paying for it, right?
Right.
We're all paying for it.
Right.
It's either whether it's
That's
directly
right.
out of our pocket or it's
Exactly.
through our insurance premiums.
exactly.
Okay.
And then ultimately, the bills, each house in the House and the Senate, they each have to pass their own bills. Then they have to go to conference and iron out all the differences because they can only present the president with one bill. So then they have to go back, they have to iron out the differences in conference and go back to each respective house,
Pass it again.
pass it again, and then send it to the president. So it's a complicated process, our democracy.
And then it will wait 2, 3, 4 years before it's effective, in fact,
Well, yes,
enacted.
that's right. Somebody asked me just the other day, well, if this passes, what am I supposed to do? How do I know what? I said, it won't take
Nothing.
effect for a number of years. You'll have plenty of time to figure it out.
Okay.
If you stay healthy.
Before I
Right.
go to the audience for their questions, Gary Jenkins is here, and he's Assistant Deputy Commissioner for Eligibility Operations, and I wondered if he wants to make some comments. There's a mic
Gary's
right
with
there.
HRAs, with the city, and when we talk about the operation of getting people enrolled in public health insurance in New York City, whether it's in the Bronx or in Brooklyn or Staten Island, Gary's the guy who makes all the offices work, or not always work, always, but he does it most of the time. And when I was invited to this highfalutin crowd, I felt I better bring somebody that really knew how it worked, in case we had a question.
Gary, would you mind
Do
coming
you
up
have
to the
anything
mic?
to add?
Good afternoon, everyone.
Hi.
Is it on?
Yeah, it's on.
Okay. First, this was a great discussion. It was very enlightening, even for me, and I help administer the Medicaid program under HRA. Our main goal is basically to reach out to uninsured New Yorkers and get them onto public health insurance. And that's, I see that as my role, and to make sure that they stay on if they continue to be eligible. So from the discussion, the panel was really enlightening to me, but for my role, we just want to make sure that New Yorkers who are eligible get onto Medicaid, public health insurance, and if they continue to be eligible, that we make that determination and they stay on.
And
Rapidly.
let me tell you, from the hospital's perspective, they do a great job on that. You really
very
get people
much.
into Medicaid. They're very aggressive about that.
Thank you.
Why was it enlightening?
That's true.
I want to see, what did you find enlightening on the what would you,
Just as far as the cost effectiveness, what's in the bill, I was a little unclear, but walking away from this panel, it gave me some more knowledge.
But the one thing that Gary just revealed is, and it's been at HRA for some time, due to state and city policies, that we are not focused in the Medicaid program on ensuring that everyone's absolutely eligible perfectly. We really focus on moving the paper quickly, determining them eligible, and so that then they have the card, and so that if they go to your
True.
hospital
That's
or
true.
somewhere else, they can get covered. And it wasn't always that way.
No, was it not.
And it does
That's true.
raise issues, but we are under no pressure from the federal government or the state government to be too concerned about it. When you're talking about 2.7 million New York City residents are on it, that's a big chunk of 8.5 million.
Well, but I think what people here need to understand is that we are the only state in the nation
Yes.
with this
Yes.
generous of a Medicaid
Right.
program.
And that's Medicaid and Family Health Plus and CHIP.
So we're
it's-
Right.
unique.
yes.
And the rest of the country, most of the people here who are covered would not be covered.
So what's the eligibility for this? Can I get on this thing?
Probably not.
Medicare.
That's right.
No, because I'm wondering, that
What is
seems
the
to be like a
basic, the
quarter.
income criteria for Medicaid?
For a family size of one, the maximum is around $767 per month.
Income.
Income. And then we have the consideration of the resources that a household may have. But fortunately, come January, the resource test will be eliminated for the SSI-related, non-SSI-related
Are you saying somebody making
go-
less,
yeah.
somebody making less than $767 a month becomes eligible for it?
Yes.
Yes.
So are you saying a quarter of New York's population makes less than
No, but that's
$700?
individuals. We're not talking about families.
Right.
But
Families,
individual-
children, with people, children in the household, the income levels go up.
Right.
And so, but that he,
Still not
he
very
assumed.
high.
It's still very low.
It's very low.
It's
You wonder
It's
how
low,
people
but it's,
can.
it's various programs that we evaluate a household for, not just Medicaid. If you're not eligible for Medicaid, then we go to Family Health Plus, and it's the age of the children. If the age of the child is under 1, then I believe it's at 133%. So it's different categories and different levels of the
But
federal
you're still
poverty
saying
level.
that a quarter of the population of New York essentially is
His income's
is
lower.
poor.
Right.
Very poor.
What we call lower income.
That's right.
One of the reasons I called,
That's amazing.
I was very anxious to have this panel, but one of the reasons I did it, and as a recommendation, is that if you can't qualify, you can actually organize a panel at a not-for-profit and get a number of doctors to come, and then they can perform a diagnosis. Because I did have a few things that I needed to bring up with Diane and John today, so I figured I could get them here and take care of that. But, you know, two of the issues that, before we open it up to people, two of the issues that have come up is, and you brought this up, Ed, and we were initially discussing this, and I think you've all said it one way, is advances in medicine and the expensiveness that these advances have encumbered the system. In other words, we have advances in technology, and yet these very advances perpetuate a problem in which you have a huge cost associated with them. And then this other one that I was trying to get Peter Singer here for this panel, but he had a piece in the New York Times Magazine which caused a lot of, all his pieces caused turmoil, because he's a utilitarian philosopher. And basically he asks the other side of this whole, is that you have, and it's the question you brought up, that a relatively small percentage of the population is responsible for a rather large percentage of the costs.
Right.
And that then brings in the question of,
Rationing. That you're afraid to say out loud.
I'm not afraid to say it.
Well,
But
I mean, in terms of the technology, you know, obviously we want people to have access to technology, but I think what they did in the Medicaid program in Maine was to say, we're going to look at if these things are proven. And, you know, unfortunately there aren't studies looking at each technology, but for instance, CAT scans of the heart to look at the coronary arteries, there are no studies to prove that, you know, it affects mortality. And so Maine will not pay for that. But there are other things, high-tech things they will pay for. So these things have to be evaluated. I don't know what we do until there are all these studies to look at effectiveness, but those studies must be done because not every scan is an advance. You know, people got PSAs for 15 years. That may not be an advance. So we really need to look at what we're spending money on.
But now there was on mammograms and so on.
well, my condition that you and I, the cardiomyopathy thing I had, my son goes to McAllister College, and he took a course evaluating, I have this condition, which they think may be genetic. So then we had to call my sons in, and my sons had to go up to Mount Sinai and have Dr. Fuster take a look at the whole family. And the amount of money that went into this whole question of, and my son said, you know, we just discussed. I have this course in medical, you know, on the repercussions of technology and medical expenditure in society. And he said, this is exactly an illustration of a waste of money. Because, yes, how many people in the population actually die of this condition of cardiomyopathy? I mean, everyone, once we found out we had it, everyone logically had to go do this. But there was no one really stopping. You know, we wanted to all do the right thing. I wanted to bring the kids in, but it all resulted in, and one of my sons refused to do it. He just said, this is too expensive.
Did they have Hallie do it because she's married to you?
Just what you were saying, the parents got insane
Yeah.
and pushed the whole thing.
Yeah, we motivated the whole, and we could do it. It was all covered.
Right, exactly. But I think the other point, just in response to you saying a very small percent of the population drives the costs, is that's actually the way it's supposed to be, right?
In
The
insurance,
people who
right.
are sick need health care. People who are healthy don't, right? So the whole point of a healthcare system is to take care of sick people. And the whole point of the insurance system is to make that accessible when you get sick. So you pay in for decades when you're not sick.
And you're
So
happy
that
to do
when you
it.
get sick, you will have access.
Right.
And so it's a tautology to say we're spending too much money on sick people. The whole point of the system is to take care of
Of
sick
course.
people. Obviously, we shouldn't be doing things that are not beneficial or that are harmful or duplicative or redundant or because of fear of lawsuit, and there's a lot of money to be saved there. But it's going to cost
But
money.
society
to take
doesn't
care
let
of
people die also when they want to,
Well,
I mean,
that's-
in our society.
That's the sort of, those are the places where money can be saved.
Okay, questions from the audience?
Yeah, if you want to come up, just come to the mic. We want-
Come to the mic right here.
Sort of question. I'm an internist, and I was an ER doc for 10 years in the city. And I think there needs to be parity in primary care medicine. You need it to be rescued, because I wouldn't advise any student to do primary care medicine today. And my other concern is on a broader sweep.
What do you mean by parity? What do you mean by, exactly?
They should be better paid.
Payment.
They should be better
Reimbursement
paid.
rates. Reimbursement issues.
Yeah.
And the other thing is campaign finance reform and the control of Congress away from a corporatocracy that has no, I studied medicine in England for a time, way back in the last century, and I was part of the National Health Service, and I didn't find it to be a repugnant thing, and I thought it was a great idea, and I think we need one here. And I think with paperless trail voting, you know, I have a concern that this sort of democratic process we think we have here is gone. And there are a lot of other things to say, but I'll stop there.
Who wants to,
Both of those
anyone
things
wants
are
to
actually-
respond?
I've seen both of those things actually, maybe not fully addressed, but at least touched on in the bills. I keep forgetting which, if it's the Senate bill or the House bill, but there is higher payment rates for primary care physicians, definitely in Medicaid. And then on the second piece, they're talking about creating a czar, health human services commissioner type of entity that would make decisions
it's
on
the
what
IMAC
is.
commission that they're talking about.
Yes, IMAC, that's right.
Mhm.
Right. Some commission that would
Right.
make decisions on what is and what isn't.
There's a lot of
covered under
controversy about
Medicare.
Well, for
that.
example, in England, if you become a GP, you make more money than if you become a cardiologist. In this country, because they wanted GPs. So they shifted the financial incentives because they have a rational healthcare system. In this country, if you be an interventional cardiologist like my husband, thank God he's very well paid because I am not. So we have the same amount of training. I would argue that I'm just as smart as he is and just as able to help my patients as he is. And as a geriatrician, I make less money per year than I would have if I had not done a geriatrics fellowship. And my husband makes a lot of money because he's an interventional cardiologist, and that is compensated much more generously by Medicare and private insurers than the primary care role that I take. So it should come as no surprise to people that no one goes into geriatrics. You can't make a living. It's very simple. But these are all policy fixes. If they were politically feasible, they could be fixed by the government.
The other thing, just in terms of payment, is not only will you get more people training in that field, but again, hopefully for the primary care physician, the reimbursement will be such that they can spend more time with the patient.
Exactly.
Right.
And it will increase the legitimacy and respect. I mean, geriatricians are at the bottom in terms of respect because they get paid nothing.
Not to me.
That makes me feel much better.
You and then,
Yeah, I have several points. One, I
okay.
want to mention the original sin, and there is a solution to the original sin. Rather than fee for service, this is what lawyers do and what psychiatrists do. It's fee per time, and you can't work 42 hours a day and bill for it. Next comment is, this is not going to work because everybody's talking about what's right for the patient. They're not looking at what counts is the money. The whole deal is the money. I will name 2 plans that could work, and we know they work. Traditional Medicare works in the United States. If we made that for everybody, it will work. Next plan that works, with one bad exception, Canadian Medicare. It works beautifully with one exception. There's not enough high-tech stuff. People have to wait for procedures. They have to wait for elective hip surgery and open heart surgery. However, the Canadians spend 10% of their gross domestic product on healthcare. We spend 17. So
We spend what?
17.
And
Therefore,
growing.
if we switched over to the Canadian system and they don't have enough stuff, and we said, we'll give 13.5% of our gross domestic product, and we already have a CAT scan and an MRI on every street corner. That would work, but there's going to be a price, and I'm going to tell you exactly what it is. Somebody's got to get hurt. And if you use the wrong words, it just doesn't work. How many times have you people said the insurance industry? It's not the insurance industry. It's the for-profit healthcare rationing organizations. And if you read the Times a few days ago, they maybe spend 60 to 70 cents per dollar on healthcare. The rest goes to profit. So you're going to have to destroy most of the for-profit healthcare rationing organizations if you want to get money. The next way to go is the drug companies. The United States of America subsidizes the rest of the world in price of drugs. I can understand subsidizing Zimbabwe for AIDS. I think the French, the Japanese, the Canadians, the Swiss, the Scandinavians, the British can kick in also. And therefore, you're going to have to cut the United States developed drug subsidy. So the drug companies will have to take a huge hit in the rest of the country. But since that's the most important thing, and those are the people who control what's going on, and it's much, much harder to change the status quo than to do something. So I think everybody's talking the wrong way. The people who are in charge of the status quo will allow some minor changes to occur. But the for-profit healthcare rationing agents, companies will still exist, because basically you can't fire 1.5 million people. But you know how many people, I believe in 1994 when the Clinton plan was knocked down, the for-profit healthcare rationing companies promised one thing. They will have one universal form for physicians to send in for reimbursements. Never happened. Doctors in practice will see scores of forms, depending on where they practice. So this is just my comment.
Who are you, by the way? You have some interesting comment. Are you a doctor? Are you what's your name? And
my name is Harvey Heschel. I'm a mostly retired physician. I worked as the director of medical education in the VA, and I was a Robert Wood Johnson clinical scholar. So I've been involved in some of these things. And when you mentioned how, you know, the law is going to go through, you're close, but it's even worse than that. Because when the bill goes to conference, whatever the Senate passes and whatever the House passes, the conference could come up with something that is in neither one of the bills. It'll be done at midnight. I remember bills being passed, I spent some time in Washington, where there wasn't a single congressman in the room. The staffers were writing the bills. So therefore, you may think this is in the House bill and this is in the Senate bill, and they're going to split the difference, or take the House or the Senate, and something totally different comes out.
Except that they have to go back and pass it. And if they change it too much,
yes,
they won't pass it in each
true,
house.
but this is what happens, and the lobbies, I mean, people talk about Medicare, Medicaid, and I read somewhere about a year ago in the Wall Street Journal, or it was the New York Times, they looked at New York Medicaid, and they used pediatric cardiology as an example, but maybe I'm wrong. New York Medicaid spent more money per recipient than any other state in the country.
That's true.
So New York has plenty of money for Medicaid. Yeah. Then they looked at where the money goes. And they said, well, you know, you can't get a pediatric cardiologist to see somebody in New York Medicaid. It's hard. Then they looked at where the money went. And New York State was 50th out of 50 states in paying for a pediatric cardiology consultation. Alaska was #1. You went to a pediatric cardiologist, they gave you $100. The 25th state paid about $50. New York State paid $22. So you can't find a pediatric cardiologist to take Medicaid in New York. New York has plenty of money, but where does it go? It goes to the hospitals. It goes to the nursing homes. It goes to the oxygen manufacturers. It goes to the ambulance companies, but it doesn't go to the deliverers of the healthcare. Why? They have the biggest lobbies, and they get control of where the money goes in Albany. Am I right or am I wrong?
I get them on, the health department.
Okay.
Thank you. Yeah, very interesting.
Yeah, we have,
you can,
Just
you
so
will
everybody's
answer
clear,
and-
I just have to, the way New York State Social Services is set up, the New York City Department of Health, of Human Resource Administration, which is our department, gets people enrolled in Medicaid. The policing of the providers and the paying of providers and all of the issues